Welcome medical students. Under head injuries and medico-legal aspects, there are three presentations. Let us discuss about scalp, skull fractures and intracranial hemorrhages during this, and in the part 3 you get practice MCQs. Starting with scalp injuries, scalp can sustain various types of injuries including abrasions, hematomas, lacerations, fractures, burns, singeing of hair. Removing hair can enhance clear examination of those injuries. Some injuries like hematomas may be felt rather than easily seen, emphasizing the importance of tactile assessment with gloved hands. Infected scalp injuries can create pathways for meningitis or sinus thrombosis. Abrasions give a clear indication of the impact site, whereas to that, forehead bruises or contusions may migrate from the initial site, resulting in periorbital hematoma due to gravity after some time. That means it does not remain static but can move or redistribute within the tissues. Now it's time to learn about the three mechanisms of causation of black eye. As you can see here, the first mechanism is if you get an impact over the forehead, the extravasated blood can seepage around the eyes, as you can see here. And the second mechanism is the direct blow. You can understand during the first thing you won't get any direct blow to the eye. However, there is a black eye. The third mechanism is again not a direct mechanism. Whenever there is a basal skull fracture, that means in the anterior cranial fossa, still you can get the seepage of blood causing black eye. Discussing further about scalp contusions, sometimes we can see contusions behind the ear or maybe surrounding the mastoid process. It indicates that a primary neck impact or middle cranial fossa fracture. As you can see here, now there are two images. Now this side where you can get bruises back of the ear or around the mastoid process is termed battle sign. And whenever you get bilateral periorbital hematoma, it is termed raccoon eyes. A battle sign means a bruising behind and below the ear around the mastoid process is due to gravitational blood accumulation from a basal skull fracture, that means in the middle cranial fossa. Now you can understand the changing of the initial site of the injury. Similarly, you can see raccoon eyes or panda eyes. Here in this case, as I have explained earlier, in case of bilateral skull basal fractures of the anterior cranial fossae lead to periorbital ecchymosis, which is termed raccoon eyes, which have resulted from periorbital ecchymosis or hemorrhages. Now learning about scalp lacerations. Scalp lacerations typically bleed more heavily than comparable lacerations on the other parts of the body. The second point is that, what do you think about this injury? Is it a cut or a laceration? You have to have a clear inspection. Actually speaking, scalp lacerations resemble cut injuries. What do you think about the reason for that? Because the scalp is on a flat bone, by application of the blunt force, it tends to split the skin with very clean edges. As a result, we need to have very close inspection by using hand lens to appreciate whether the head hairs are cut or hair bulbs had been crushed. What about the underlying bone, whether it's cut or crushed? What about tissue bridging? And also we can have a look about the surrounding abrasions as well to differentiate whether it is a cut injury or a laceration. Now you can understand here. Now it is very clear to see it is a laceration with irregular margins and irregular base. Learning some more parts of scalp lacerations, degloving injuries and pattern lacerations. First of all, degloving injuries, that means it is a result from a shearing force that separates the skin from underlying tissues and muscles. Whenever there is a sudden and strong forces, basically in a form of rotatory movement, such as in industrial or machinery accidents, or in case of runover injuries, there may be degloving injuries. As you can see here, now this flap of skin had been separated from the underlying injuries. You can see a nice tissue bridging as well. And the next type is pattern lacerations. That means by studying the pattern laceration, you can reconstruct the causative weapon and the shape and etc. Now with the pole, you might get a simple split. As you can see here, elongated injury which is sutured, but you can see very nice surrounding abrasions. So you can reconstruct. And the next example is when scalp is assaulted with the hammer face blow, still there may be pattern lacerations in the forms of stellate shaped laceration, or it could be a circle or maybe just an arc, as you can understand here. So it helps to reconstruct the causative weapon, and also sometimes the incident happened. Shifting to skull fractures, the first one is linear or fissure fractures. These are straight or curved fracture lines, often of considerable length. These are basically due to low velocity impacts when the fracture lines are very narrow. You can see here a nice fissure fracture. The second one is depressed fracture. These are due to focal impacts with a considerable force, making the outer table to be driven inwards. If the force is not absorbed by the diplo, the inner table will also usually be intruded into the cranial cavity with all the dangers of direct damage to brain. Now you can understand if the overlying scalp had been injured, that means there is a connection to the exterior. So that means we termed such fracture as a compound fracture as well. So now we can tell depressed compound fracture. Whereas to that, if the overlying scalp is not damaged, it is a depressed simple fracture. The next type is pond fracture, or in other words, ping pong fracture. Since the nerve bones are very pliable, don't get basically a depressed type of fracture. Instead, we get just a depression over the pliable bones. Let's try to apply the knowledge that we gain. What do you think about this fracture? It's very roundish. You can see just a depression, and also you can understand it is very localized fracture. So can you reconstruct the weapon caused? It is basically the hammer face. And the next one is, what do you think about this one? Any idea about the causation of these injuries? When you compare to this one, this is very localized, but when you are going to think about this skull, it is basically a diffuse application of a diffuse force. What do you think about this one? You can see a very nice bone cut with certain fractures here and there. So now this is how that we are going to reconstruct the incidents and the causative weapons. To illustrate some more images, note the elevated fracture. In here, the fractured segment is elevated above the level of the remaining skull, as you can see here. It is usually caused by sharp weapons while tilting the blade. Next one is application of sharp force with a heavy sharp instrument. You can see a very nice cut injury here. Chipped fracture. That means it is caused by when a blade of a heavy sharp cutting instrument passing tangentially at the specialized sites such as eminences. Next one is penetrating fracture or bony deficiency. That means when an object pierces the skull, creating an open wound like you can see here. Now there's a little difference in between penetrating trauma and perforated trauma. If the object passes through and through, it causes perforating trauma when compared to this. This is penetrating, just penetration only, not through and through. Spider's web or cobweb fractures. It is a complex pattern resembling a spider's web, as you can see here. At the site of impact, it is get a circular fracture surrounding the impact, and also there may be radiating fractures from the initial impact and outwards. The next type is gutter fracture. When a bullet grazes the skull causing a gutter of the outer table, not involving the inner table, it is termed gutter fracture. That means it's very superficial, not opening into the skull cavity. The next type is growing skull fracture. Actually, it is not a fracture type. However, it is a complication of an infant fracture. Usually, it develops following a linear fracture with an underlying dural tear, resulting in herniation of the brain when an underlying dural tear fails to heal properly. So, it happens progressively and over a period of time. Next type is comminuted fracture. Usually, whenever there is a fracture on a bone, we get two pieces with the fracture line. However, if we get more than two pieces due to fractures, it is termed comminuted fractures, as you can see here. Now again we can reconstruct the incident happened. This is not a very localized force, but it is somewhat diffuse but severe force, as you can understand. If it is a localized force, there could be a depressive type of fractures. The next type is ring fractures. It happens over the base of the skull, and it is seen surrounding the foramen magnum, as you can see here. It is due to the compression of lumbar spine after a fall landing on feet or buttocks, or else it could be due to a heavy blow onto the vertex, causing fractures surrounding the foramen magnum. It is believed that because due to these fractures, it causes immediate death because of the immediate vicinity of the brainstem. The next fracture type is contusion fractures that you are going to learn during the part 2 of head injuries. Next type is diastasis of the cranial sutures, usually seen in young people, as you can see here. What do you think about bony deficiencies? Are they fractures? Definitely, because you can see the discontinuation of the bone, so you can name it as a fracture. In case of firearm injuries, you will be getting entry injuries and exits. So you see those injuries as bony deficiencies, but you are not going to name it as a kind of or special kind of fracture, just I have described here. Learning about medico-legal importance of fractures, Pape's rule. This is related to the sequence of fractures. Imagine in this skull vertex, you can see two firearm entry wounds. Which one is the first one? Now, according to the Pape's rule, now it is mentioned that lateral fracture will be interrupted by an earlier pre-existing fracture line. As you can see nicely here, now when this radiating fracture goes like this, it can't pass this green color fissure fracture. So that means this firearm entry wound should be first in the sequence. And second one is this one. That's why this radiating fracture can't cross this line. Infections and other complications. As early complications, there may be meningeal hemorrhages, brain damages, and also there may be late complications such as infections, such as through sinuses, or maybe due to through the nose following fracture of ethmoid bone, etc., etc. And what do you think about categorization of hurt? If there is a fracture, according to the section 311 of the Penal Code, limb G, it is categorized as grievous. Next one is post-traumatic epilepsy. Whenever there is depressed skull fracture, there is a possibility of getting post-traumatic epilepsy, and it has to happen within 2 years of the traumatic episode. Next one is compensation. Due to delayed neurological damages, there may be lots of litigation issues in relation to compensation. So far we have covered scalp and skull fractures. Now we are moving on to meningeal hemorrhages. There are three basic meningeal hemorrhages: extradural hemorrhage, subdural hemorrhage, and subarachnoid hemorrhage. Now we are going to learn about extradural hemorrhage. What do you think about the definition? It's a collection of blood between the inner surface of the skull and the outer layer of the dura. Here we are going to learn about a classic extradural hemorrhage only, and there may be lots of variations as well. The etiology is traumatic, as in cases of assault, road traffic injury, falls, sport injuries. As per the pathophysiology, classically, an EDH is formed right below the impact point, accompanied by a skull fracture. However, there may be occasions where you get an EDH at the impact site without a fracture even. It is due to the malleability of developing skull in children. What is the source of bleeding? Usually it is arterial, mostly with a torn middle meningeal artery or its branches. As you can see here in the picture to the right, you can see the branches of the grooves for middle meningeal arteries. If there will be a fracture like this, what will happen to the artery associated? That artery also get damaged, causing extradural hemorrhage. However, there may be venous extradural hemorrhages as well due to torn sinuses as well. The incidence of acute EDH is high in young people, not among extremes of age. The reason is, in extremes of age, it is believed that the dura is tightly attached to the skull. The appearance of EDH is typically biconvex in shape, and because it can cause a mass effect with the formation of space occupying lesion as well. When the blood clot is evacuated promptly, it is believed that the prognosis of extradural hematomas is generally good. The attempt here is to compare all three meningeal hemorrhages. As you can see here, you can see the dura mater here, and you can see the hemorrhage external to the dura mater. So it is termed extradural hemorrhage. But when it comes here, as you can see, now this is the skull cap and this is the dura, this is the brain. You can see now it is below the dura, so it is subdural hemorrhage. When it's come to this picture, you can see the scalp removed and the dura. However, you only can see hemorrhages within the para-arachnoid. So as a result, this is a case of subarachnoid hemorrhage. Discussing about clinical presentation of acute subdural hemorrhage is interesting. Imagine this is the place where the person gets the trauma. So with this, He might get a fracture most of the time. With this fracture, it tends to damage the branches of middle meningeal artery. And immediately he regains the consciousness, and after a while only he will be experiencing another episode or the second episode of loss of consciousness. So what are the things that are happening during this period, which is termed latent equals normal period or lucid period? So that means in between these two episodes, the person is said to be basically normal. So what will happen here with the fracture resulting in the tearing of the branches of middle meningeal artery, there will be bleeding inside the skull. So it takes time to develop neurological deterioration. So until such time, the person is normal or lucid. That's why this period is termed as lucid interval or latent period. However, we should not rely 100% on this classical picture, because there may be instances where a person may lose his or her consciousness with the first time and without a lucid interval. And also there may be instances where person gets the trauma here but no loss of consciousness, but after a while he or she develops the bad second or the first episode for him with the neurological deterioration. So as a result, as doctors, we have to be very careful about the clinical presentation of extradural hemorrhage, and we can't rely on the classical presentation with the lucid interval. Moving on to the medico-legal importance of extradural hemorrhage. So this is the least common of the three types of brain hemorrhages as I have described earlier. The latent or lucid interval in both extradural and subdural hemorrhage may lead to civil suits for negligence where a doctor, usually in a hospital emergency department. So you have to be very careful when people are presented with head trauma. If the person presented within the first 24 hours, the differential diagnosis is between extradural hemorrhage, subdural hemorrhage, or cerebral fat embolism. So that means in case of subdural hemorrhage or in cerebral fat embolism also, you will be experiencing this lucid interval in between the first and second episodes of loss of consciousness. Third one is extradural hemorrhage is never a contraho injury. That means the bleeding happens next to the impact site. Most extradural hemorrhages are associated with skull fractures, but there may be cases without skull fractures as in children. The usual site is unilateral and also seen mostly on parieto-temporal areas. And also we have to keep in mind that in chart bodies there is a mimicking artifact called heat hematoma. Heat hematoma is formed due to the exudation of blood from the diplo and venous sinuses due to the high temperature, actually into the extradural space. So the heat hematoma and extradural hemorrhage may be mistaken for an inexperienced eye. And the next one is categorization of hurt due to extradural hemorrhage. Always remember, we have to go by the amount and the thickness and also along with the clinical features. So accordingly, we have to categorize it. Sometimes prompt and proper intervention is necessary, categorizing it as fatal in the ordinary course of nature, or sometimes maybe endangering life. What is the causation of EDH, spontaneous or natural? Typically, it arises from traumatic incident. Reaching towards the second type, subdural hemorrhage. It is a collection of blood below the dura but external to the arachnoid membrane. What is the pathophysiology here? It is almost always venous due to tearing of subdural cortical bridging veins that we are going to have a look of nice images later. It happens due to the stretching and tearing of bridging cortical veins as they traverse the subdural space toward dural sinuses. Demography. It can happen at any age, but it is most common at the extremes of life. Any explanation for that? In case of elderly, brain get atrophied, and also there may be lots of fragile blood vessels. So with the movements, rotatory movements and so on, there may be lots of trauma to these cortical bridging veins. And in case of infants, the relatively larger head supported with underdeveloped neck muscles, making the head more vulnerable to rotation, and as a result, there may be tearing of blood vessels causing subdural hemorrhages. Moving on to the images, first of all, I want to pay my utmost gratitude for these images. Bridging veins. So now I want to emphasize the importance of subdural hemorrhage based on bridging veins. You can see dura here, you can see the cerebral cortex where superficial veins are connecting through the cerebral or venous sinuses. When there is a break here, you can see subdural hemorrhages obviously. Please note dura, subdural space, arachnoid, CSF, and pia. Whenever there is an atrophy in cerebral cortex, as in chronic alcoholics or in old age, or actually infants, the distance of this bridging vein is causing more rotational effects, or there is a susceptibility of getting more subdural hemorrhages. Have a look of this emissary vein where it goes right through the scalp, through the bone, up to the venous sinuses where infection can pass up to the sinuses, and also dip-like vein as well. What are the circumstances that might get subdural hemorrhages? It is almost always traumatic. Far less common causes such as vascular malformations and intracranial aneurysms are also described. As a result, it is termed almost always traumatic. But in case of extradural hemorrhage, we discussed it as always traumatic-like. And also in EDH, we got mainly in the classical picture arterial blood. Here we get venous blood. Typically, this is crescent-shaped and may freely move in the cranial cavity, producing the typical crescentic shape. There may be three types of subdural hemorrhages based on the time of presentation. So these are the three stages: acute, subacute, and chronic. Prognosis tend to depend on the extent of the bleed and associated mass effect. There are a few mechanisms in causing subdural hemorrhage. The first one is a rupture of bridging cortical veins due to the trauma-induced rotational movement of the brain. Second one is burst lobe. Burst lobe means, if I just draw like this, if this is the dura and if this is the brain, and if there is a traumatic contusion injury here, if this contusion is burst into this subdural space, there may be a subdural hemorrhage. And the next one is if there is an open or comminuted fracture penetrating all the way up to this, so still there may be subdural hemorrhage as a part of complex injuries such as subarachnoid and cerebral laceration and contusions. So this is just one of the parts of complex injuries. And the next one is if there are cortical hemorrhages or sinusoidal injury, still there may be subdural hemorrhages. Subdural hemorrhages are divided into different categories depending on the time period that had taken to show clinical features. If clinical features appeared in between 1 to 3 days, it is termed acute one. And then 3 days to 3 weeks, subacute, and more than 3 weeks, it is chronic one. In case of acute subdural hemorrhage, bleeding occurring in the last 1 to 3 days after the trauma. It is characterized by fresh liquid blood. So there are no membranes, it's just a blood accumulation under the dura. When it comes to subacute one, that means 4 days and 3 weeks, so there may be lots of changes that can be noticed there. So there may be fibroblast growth started from the dural side forming outer membrane. So by studying histologically these features of the membranes and the blood clot and so on, we can take the subdural hemorrhages. Moving on to the chronic subdural hemorrhage, here actually 3 weeks had been elapsed after the trauma. Symptoms may not appear for weeks or months even, or maybe years. With the time, the clot undergoes organization and layers of different densities are there, including more solid and liquefied components as well. And also, by the time chronic SDH, the whole bleeding had been encapsulated from outer and inner aspects as well. So by studying these features, maybe the density, maybe the histological features, maybe the membrane thickness, outer and inner, we can date the subdural hemorrhage. And also there may be acute and chronic one as well. That means there may be secondary bleeding due to recurrent minor traumas as well, which is termed acute and chronic subdural. Let's formulate an opinion in these subdural hemorrhages. What do you think about this one? Can we see any membranes or adherence to the dura? No, these are basically somewhat fresh subdural hemorrhages. These are loosely attached, somewhat clotted blood. But when it comes to here, what has happened, you can see the clot had been attached firmly to the dura. So that means it had been some time with this hemorrhage, whereas to that here it is basically acute one. Now it's time to discuss about medico-legal importance of subdural hemorrhage. As we have described earlier, much more common than extradural hemorrhage. As we can remember, now I have explained clearly, in case of extradural hemorrhage, we get a fracture at the site of extradural hemorrhage most of the time. However, when we think about the mechanism of causation of subdural hemorrhage, we discussed about rotational movements resulting in damage of cortical bridging veins. So you can understand there is no role to play with the fracture. And what do you think about the mechanism of causation here? Is basically acceleration, deceleration with rotational component. But in case of extradural hemorrhage, it is basically a direct trauma. And subdural hemorrhage is somewhat mobile. Not like extradural hemorrhage, it is very discoid blood clot. But here, there may be some kind of fluid dynamic or movement around the brain hemispheres. And what are the risk factors for subdural hemorrhage? In elderly and in alcoholics, actually there is a higher risk of getting subdural hemorrhages due to cerebral atrophy, or maybe due to anticoagulant treatment or liver failure, etc., etc. Not like extradural hemorrhage, subdural hemorrhages may be bilateral, or may be isolated, or may be combined with fracture even. We can't say no. Are there spontaneous subdural hemorrhages? Yes, there may be, very rarely, spontaneous ones as well, due to coagulation issues, birth-related factors, and also inherited metabolism disorders, vascular anomalies, and so on. What do you think about the forensic interpretation of subdural hemorrhages? It is essential to consider about macroscopic, microscopic, and all the available findings along with the history to prevent errors in the final judgment. If we are going to tell wrong thing, that means we are going to give wrongful accusations at time. What do you think about the origin of subdural hemorrhage? The question is, it is injury related or non-injury related. As we have described, there may be occasional spontaneous one as well. So there may be false allegation that this person had been assaulted by A. Actually meaning it could be due to a natural cause as well. And what do you think about subdural hemorrhage and shaken baby syndrome? These two are commonly associated, and you have to know about that fact as well. And categorization of hurt, very similar to extradural hemorrhage, will depend on the clinical features. You have to collectively look at the picture, and there may be certain subdural hemorrhages where we can manage symptomatically. So we are going to categorize that one as endangering life. However, there may be large subdural hemorrhages necessitating prompt and proper treatment, categorizing it as fatal in the undue course of nature. Presence of a thin layer of SDH, do you think that it will cause death? Now, it is challenging to attribute the cause of death as subdural hemorrhage. However, remember, with the force that is enough to tear bridging veins, there may be certain other concomitant brain damage. So this could be the reason to die. The next one is similar to epidural hemorrhage. There may be latent periods as well. So we have to be very careful about the presentation with subdural hemorrhages. And it could be an incidental finding in elderly. As we have described earlier, the person is going to die with definitely a different cause, but subdural hemorrhage, most probably a chronic one, could be an incidental finding due to the atrophy of brain or recurrent falls. So nobody is going to notice it. It is just there. As with the extradural hematoma, the position of a subdural hemorrhage can never be interpreted as a contractile lesion, and as a result, no use of differentiating a blow from a fall. But in case of extradural hemorrhage, we have described, it will happen at the site of impact. Subdural hemorrhages are a result of rotational and other movements. As a result, we can't locate an exact point in causation of subdural hemorrhage. The third type of membranal hemorrhage is subarachnoid hemorrhages. As per the definition, it is the bleeding into the subarachnoid space, consists inner layer, that means pia, and middle layer arachnoid matter, and this place is usually occupied by the cerebrospinal fluid as well. This type of hemorrhage is more common than subdural hemorrhage, and also it could be focal, only basal, or in the vertex, or involving the whole brain. Importantly, there may be two different sources. It could be due to trauma, and also it could be due to natural causes as well. What are the traumatic causes? secondary to falls, gunshot wounds, motor vehicle accident, blunt force trauma, brain contusions, and lacerations. While discussing about natural causes, it could be mainly due to perianeurysm rupture, vascular malformations, and certain other systemic diseases with increased incidence of vascular fragility such as Marfan syndrome and etc. etc. However, whenever there is a damage to cortex, there will be some degree of subarachnoid bleeding as well. So whenever there is a penetrating injury, basically we experience subarachnoid hemorrhage at that place as well. You can see here a focal hemorrhage. So this is focal subarachnoid hemorrhage. Here we can see diffuse hemorrhage, diffuse subarachnoid hemorrhage. Here you can see a thick basal subarachnoid hemorrhage along with diffuse subarachnoid hemorrhage. Moving on to the last part of the theory, medico-legal importance of subarachnoid hemorrhage. Dating of hemorrhage is equally important by using gross and microscopical findings. If it is a little subarachnoid hemorrhage, there is a possibility of absorbing into cerebrospinal fluid. Differentiation of traumatic and natural subarachnoid hemorrhages, I am not going to discuss. You can understand the importance there. Thick basal subarachnoid hemorrhage causes sudden death due to the brainstem involvement and arterial spasm causing respiratory depression. However, when the subarachnoid hemorrhage is not that severe or very thin, what do you think about the cause of death? Now, it is very obscure to arrive at the mechanism of death. And the next thing is aneurysm-related conflicts. Imagine a situation, a 65-year electrician was experiencing mild headache, dizziness and so on. Actually, he didn't care about it and he went for work on a particular day. So on that day, now this is the time that he started his mild symptoms, but nobody worried about it. And after a while, one day he had gone for his duty, and while he was changing a light bulb after climbing a ladder, suddenly he had fallen and died. During the post-mortem, it was found that there was actually ruptured perianeurysm. However, the wife of the person wanted to have a legal action against the employer, indicating that the employer was negligent. Now the dilemma is what? Whether was there a leaking aneurysm that made him to fall from the ladder, or else the fall itself caused the rupture of the perianeurysm. So now these are the medico-legal implications that we have to solve. Basal subarachnoid hemorrhage may be due to natural causes such as ruptured perianeurysm, and also may be due to traumatic causes as well, such as in basilovertebral artery injury. Rotational trauma to head and upper neck can result in basilovertebral artery injury. One of the hypotheses is CV1 syndrome. It suggests that a blow to the neck may damage the vertebral artery, causing dissecting lesions leading to upward fatal subarachnoid hemorrhage. If this is the neck and this is the head, at the level of cerebral vertebra 1, there may be damage of the vertebral artery causing upward fatal subarachnoid hemorrhage. And also earlier it was believed that there were fractures as well at the first cervical vertebrae. However, Later, it was identified that without fracture it can happen, and also with the trauma there may be fatal subarachnoid hemorrhage as well. The next one is with the subarachnoid hemorrhage there may be delayed complications such as hydrocephalus, and also cerebral edema rarely can cause due to the usual healing process or as a secondary damage to the initial injury. This brings to an end of the part 1. Part 2 has got many aspects like this. You can read it. And part 3 covers practice MCQs with explanations. Thank you.